Chapter 6 is Medicare. Our lesson objectives for this chapter explain the history of Medicare, explain eligibility criteria for Medicare, abstract important information from a patient's Medicare card, identify the benefits of Medicare, list 5 federal laws adopted to increase health benefits for employed elderly individuals, explain various Medicare programs and other insurance coverage combinations. Name the federal program that relates to utilization and quality control of health services. State the benefits for a participating versus non-participating provider. Explain the 2 different types of Medicare coverage policies that must be adhered to. Explain when to obtain a patient's signature on an advance beneficiary notice of non-coverage. Identify non-covered Medicare services. Define and discuss a Medicare prepayment screen. Discuss the different Medicare payment methodologies. Explain the resource-based relative value scale system that Medicare uses to establish fees. Explain how the Medicare Access and CHIP Reauthorization Act of 2015 will affect Medicare reimbursement in the future. State the Medicare mandatory claim submission guideline and define a Medicare administrative contractor and explain their responsibilities. Determine the time limit requirement for transmitting a Medicare claim. State the components of a Medicare remittance advice and explain the importance of identifying Medicare overpayments. Starting with policies and regulations, we have the CMS, which is the Centers for Medicare and Medicaid Services Division. And the CMS oversees traditional fee-for-service Medicare. The Centers for Medicare Advancement. We have the Center for Beneficiary Choices. These provide patients with information about Medicare. The Center for Medicare and State Operations, who focus on federal state programs. Eligibility requirements for Medicare. This is for people 65 and older who are retired on Social Security, people 65 and over who are retired from railroad or civil service, the disabled, children and adults with chronic kidney disease, and also kidney donors. By 2027, full-time retirement age will be 67 for people born after 1959. And an individual can enroll in Medicare 3 months before their 65th birthday. So that way they are actually, their Medicare is activated right on their 65th birthday. Medicare Part A hospital benefits. This is for hospital stays up to 90 days, nursing facilities up to 100 days, home health care services, psychiatric hospitals, and hospice and respite care. Medical Part A is hospital insurance for the aged, disabled, and blind. Funds come from special contributions. Hold on 1 second, sorry. Sorry about that. Come from special contributions from employees, employers, and self-employed people, collected along with regular Social Security contributions. A benefit period. This is going to be a period of time for which payment for Medicare inpatient hospital benefits are available. For hospitals, 90 days for each period. nursing facility for 100, and there are extended care days for each period. Hospice is a public agency or private organization primarily engaged in providing pain relief, symptom management, and supportive services for terminally ill patients and their families in their own home or in a center that is home like. And then respite care is a short term hospice inpatient stay for a terminally ill patient to give temporary relief to the person who actually takes care of them at home. Then we have Medicare Part B, which is medical and preventive care benefits. This is for medical expenses, clinical laboratory services, home health care, outpatient hospital care, and also blood work. How much Medicare will pay does depend on the service that's provided. In 2010, the Patient Protection and Affordable Care Act made preventive measures free to Medicare beneficiaries, such as screening for colon, prostate, and breast cancer. Then we have Medicare Part C, which is a Medicare Advantage plan, and the following are options for the available plans: HMOs, POS, PPO, PFFS, PSO, RFBS, and MSA. All of these abbreviations are on the previous slideshow for your key terms and abbreviations. Health maintenance organizations, point of service plan, preferred provider organization. These are what these abbreviations are: private fee for service plan, provider sponsored organization, religious fraternal benefit society, and medical savings account. Medicare Part C, Medicare Advantage plan, increases the number of healthcare options. Part C goes beyond Parts A and B to increase choices for enrollees because enrollees can get a high deductible insurance policy. Medicare pays the premiums and deposits money into a medical savings account for the patient's use in reaching the deductible. It's important for the medical office billing specialist to become acquainted with Medicare Part C because some patients may be eligible for it. In 2010, national healthcare reform legislation froze payments to these plans with cuts in the following years. It is predicted that enrollees may lose some benefits, such as free eyeglasses and also hearing aids. Next, we have Medicare Part D. Medicare Part D covers prescription drugs for conditions not covered in Part A or Part B. It's a prescription drug benefit. It became effective January 1st, 2006. Eligible Medicaid Medicare member pays no premium or deductible. It's a tiered drug plan, and you can check Medicare information for authorization requirements. 2 ways to obtain Medicare Part D is to join a Medicare prescription drug program that adds drug coverage to the original plan, or to join a Medicare Advantage plan, such as an HMO or PPO, that includes prescription drug coverage as part of the plan. And while we're on the topic of drug plans, a formulary, this is a list of drugs that a health insurance plan covers as a benefit. Classes of drugs that are excluded from coverage include barbiturates, benzodiazepines, drugs for cosmetic purposes, drugs for symptomatic relief of cough and colds, drugs for weight loss or weight gain, erectile dysfunction drugs, fertility drugs, prescription vitamins, or minerals, and that is excluding prenatal. In 2010, national healthcare reform legislation provided a $250 rebate for all Medicare Part D enrollees who cross into the donut hole to help pay for drugs. Patients in the coverage gap received a 50% discount on brand name drugs. Federal government will provide subsidies for brand name drugs beginning at 2.5% and will increase to 25% by 2021. In 2011, it began subsidies for generic name drugs at 7% of the cost. Railroad retirement benefits. This is medical insurance premiums that are automatically deducted. Entitled to benefits for covered services at a qualified American facility. Some may be members of the Railroad Hospital Association, prepayment plans, and contracts with Medicare. Railroad Retirement Board offices maintain eligibility records for Medicare. Many prepayment plans make arrangements for Medicare to receive direct payments for services it furnishes under Medicare Part B. The Medicare Railroad Retiree Carrier is usually a different regional Medicare administrative contractor than the standard MAC. Employed elderly benefits. Federal laws and regulations include the Omnibus Budget Reconciliation Act, known as OBRA, the Tax Equity and Fiscal Responsibility Act, known as TEFRA, the Deficit Reduction Act, known as DEFRA, Consolidated Omnibus Budget Reconciliation Act, known as COBRA, and the Tax Reform Act. Many federal laws define Medicare benefits. And all of these are listed and explained in your textbook in box 6-1 in chapter 6. Some additional insurance programs. Some other types of insurance under which a patient might be covered include Medicare, Medicaid, known as Medi-Medi, Medicare, Medigap, managed care plans, and private insurance. Determining if Medicare is primary or secondary, you should always ask about any other insurance, copy their Medicare card, ask about supplemental coverage, call the carrier, and make sure to bill correctly. Be sure to copy both sides of the Medicare card and call the carrier if the type of plan is not clear to you. Medicare managed care plans include health maintenance organizations, risk and cost plan, carrier dealing prepayment organization. When a non-contract physician treats a Medicare HMO patient, the medical office staff should keep the following in mind. It should be a Medicare-covered, medically necessary emergency service that was previously authorized or approved. The patient pays if there was no emergency, or otherwise the physician will be paid according to the medical fee schedule. Practices of 12 to 15 physicians can run their own insurance plan if contracted with the government, but they need to be incorporated and have their own Medicare provider number. For risk plan, beneficiaries receive Medicare-covered services from providers who are contracted members of an HMO network. Enrollees are called restricted beneficiaries. For cost plan, beneficiaries receive Medicare-covered services from sources in and outside of the HMO network, and enrollees are called unrestricted beneficiaries. As far as the conditions of enrollments in an HMO risk plan go, risk plan beneficiaries only receive Medicare-covered services from providers who are contracted members of the HMO network. The benefits differ from a cost plan because cost plan beneficiaries can receive Medicare-covered services from providers outside of the HMO network. Carrier dealing prepayment organization may be set up by a medical practice under contract to the government. Patients sign a contract agreeing to a monthly fee, usually between $20 and $25. It's supposed to cover all Medicare copays, deductibles, and non-reimbursable expenses. Practices of 12 to 15 physicians are opting to run their own plans instead of being run by HMOs. Utilization and quality control. Quality Improvement Organization contracts with the CMS to review medical necessity, reasonableness, appropriateness, and completeness and adequacy of care. QIO is a state-based group of physicians reviewing cases for hospital admission and discharge, formerly known as professional or peer review organizations. The Federal False Claims Amendment Act is another federal law to prevent overuse of services and to spot Medicare fraud. Offers incentives of 15 to 25% of any judgment to informants who report physicians suspected of defrauding the federal government. The Federal False Claims Amendment Act affects the medical office because incentives make whistleblowers more likely, and whistleblowers are those informants who report. CLIA, the Clinical Laboratory Improvement Amendments, establish federal standards, quality control, and safety measures for all freestanding laboratories, including physician office laboratories. When claims to MACs are submitted for laboratory services performed in the physician's office, the 10-digit CLIA certificate number should be entered into Block 23 of the CMS 1500 0212 claim form. Payment fundamentals. Here we have participating, non-participating physicians and prior authorization. In a participating physician agreement, a physician agrees to accept payment from Medicare, and that's 80% of the approved charges, as well as the patient portion, which is 20% of the approved charges. And this is all after the $147 deductible has been met. A participating physician has an agreement with Medicare. A non-participating physician does not have a signed agreement with Medicare. Non-par physicians receive 95% of the Medicare approved amount, but non-par physicians may decide on a case-by-case basis whether to accept assignment. If the physician does not take assignment, he or she may balance bill the patient, which is 115% of the non-par rate, because Medicare will send the payment to the patient. Before signing on with Medicare, the physician should consider if balance billing and collecting the fee from the patient is worth the extra percentage of allowed fees. Also, balance billing can be limited in certain states. Waiver of liability provisions. First, we have an ABN, Advanced Beneficiary Notice of Non-Coverage. You should have the patient sign if you expect Medicare to deny payment, entirely or just part of it. Refer to National Coverage Determinations, which are NCDs, and I should say Local Coverage Determinations, which are LCDs, to determine which services require an ABN. Non-covered services require a notice of exclusions from Medicare benefits, and patients are responsible for payment. This should be made clear before service is rendered. Patients can be billed for non-covered services. Next, we have elective surgery estimate. The term elective surgery means a surgical procedure that can be scheduled in advance, is not an emergency, and is discretionary on the part of the physician and the patient. A non-participating physician who does not accept assignment for an elective surgery, for which the actual charge will be $500 or more, must provide the following in writing: an estimated fee for the procedure, estimated Medicare approved allowance for the procedure, and also the difference in the physician's actual charge. The chronology of the prospective payment system. We have the Social Security amendments of 1983. Hospitals treating Medicare patients are reimbursed according to pre-established rates for each type of illness treated on the basis of diagnosis. Then we have DEFRA, the Deficit Reduction Act, participating physician program that offered incentives to participating physicians and froze the fees of non-participating physicians. Then the Omnibus Budget Reconciliation Act of 1987, which introduced the maximum allowable actual charge, known as the MAAC formula. Medicare reimbursement. Diagnosis-related group numbers establish the rates of payment for each type of illness. A reasonable fee is the amount Medicare participating providers agree to accept for a given service. The patient may only be billed 20% of the Medicare allowed charge if the physician accepts assignment. A resource-based relative value scale is the system that Medicare uses for establishing fees, taking into account work value, overhead expense, and malpractice values for all CPT codes that are published in the Federal Register. The Healthcare and Common Procedure Coding System was developed by the federal government for Medicare to obtain correct payment for a procedure or service. A code number must be selected from level 1 or 2 of the HCPCS coding system. Prepayment screens are when Medicare limits the number of times a given procedure can be billed during a specific time frame. The Physician Quality Reporting Initiative is a pay-for-reporting program for providers who bill under Medicare Part B. The Recovery Audit Contractor, known as a RAC. This program's goals are to identify Medicare underpayments and overpayments and recover overpayments using automated review and complex review. The Resource-Based Relative Value Scale, or RBRVS. This is designed to create fair reimbursement. And it has a formula. It involves choosing a HCPCS CPT code using the relative value unit, or RVU amounts, listed in the Federal Register for work value, practice expense, and malpractice value. Takes this and multiplies each by the Geographic Practice Cost Indices, or GPCIs. Then to obtain the total adjusted RVU, you're going to add the three amounts together. Finally, to discover the allowed amount for this code, multiply the annual Medicare conversion factor, or CF, by the HCPCS CPT codes. Excuse me. HCPCS CPT codes total adjusted RVU amount. Prepayment screens. Medicare limits the number of times procedures can be billed during a specific time frame. Computer screens do trigger these suspensions of processing. If the claim was previously submitted for the procedure performed in the allotted time frame by another physician, the claim will be downcoded or denied. You should refer to the local MACs transmittals, formerly known as program memorandums, or contact the contractor for a complete list of the Medicare prepayment screens that are applied locally. Three initiatives. We have Correct Coding Initiative to eliminate unbundling or other inappropriate reporting of CPT codes. Physician Quality Reporting Initiative, a pay-for-reporting program for providers who bill under Medicare Part B. And then we have the RAC Initiative, Recovery Audit Contractor, to identify Medicare underpayments and overpayments and recover overpayments using automated review and complex review. Automated being computer review and complex being human review. The Recovery Audit Contractor RAC Initiative originally created a demonstration program that became permanently implemented when Congress enacted the Tax Relief and Health Care Act of 2006. This extended the RAC initiative to all 50 states by 2010. For claim submission, we have local coverage determinations. This is a decision by the MAC whether to cover a particular service on a contractor-wide basis in accordance with the Social Security Association. So, a determination as to whether the service is reasonable and necessary. MACs are organizations handling claims from physicians and other suppliers or services covered under Medicare Part B. FIs, or fiscal intermediaries, are organizations handling claims from hospitals, nursing care facilities, intermediate care facilities, and other home health agencies. Fiscal agents are organizations that handle claims from physicians and other suppliers of services covered under Medicare Part B. Patient signature authorization. Signatures must be retained. It's called a signature on file, or SOF. That's what it's abbreviated as. Some special considerations in obtaining and filing the patient signature authorization should be kept in mind. If the person is illiterate or physically handicapped, confinement in a facility, they have a Medigap claim, a deceased patient, or a Medi claim, which is the Medicare Medicaid claim. For time limit, beginning October 1st, 2009, providers no longer have 15 to 24 months to file and must submit claims within 12 months of the date of service. For exceptions in which patients are allowed to submit claims to Medicare are services covered by Medicare for which the patient has other insurance that should pay first, services provided by a physician who refuses to transmit the claim, services provided outside the United States, situations in which durable medical equipment is purchased from a private source. Healthcare reform of 2010 changed the filing deadline for claims. On assigned claims, the provider may file without penalty up to 27 months after providing service if reasonable cause for delay is shown to the insurance carrier. Patients are not allowed to submit claims to Medicare, with those 4 exceptions. For claim submissions, we have Medicare Medicaid claims, Medicare Medigap claims, Medicare Employer Supplemental Insurance claims, Medicare Supplemental and Medicare Supplementary Payer claims, claims for deceased patients, and physician substitute coverage. For Medicare Medigap claims, to ensure the crossover of the Medicare Medigap claim, for paper claims, you should complete blocks 9 through 9D of the CMS 1500 form. For claims for deceased patients, 2 ways to submit billing for a patient who has died. Participating physician accepts assignment on the claim form of the electronically transmitted claim. The non-participating physician does not accept assignment, bills Medicare, and submits the following: the CMS 1500 form signed by the estate representative who is responsible for the bill, a statement or claim for all services provided, the name and address of the responsible party, and the provider's statement signed and dated refusing to accept assignment. Nothing can be done about the open balance on the account until the estate is settled, and then Medicare will pay. After claim submission, we have the remittance advice, known as an RA, or the Medicare summary notice, known as an MSN. Remittance advice, formerly known as the explanation of Medicare benefits, is a document that Medicare sends to participating physicians. The front side lists codes representing the reason a claim may not have been paid in full or was denied. The codes are defined on the reverse side. Some examples of information on the Medicare remittance advice include whether the claim was paid in full, the allowed amount, the disallowed amount, if the claim was transferred to another carrier. And then your Medicare summary notice, MSN, is a document sent to the patient that is similar to an RA, identifying the same items related to the claim. So the remittance advice, or RA, goes to the physician, or the MSN goes to the patient. Beneficiary representative payee, for posting payments and reviewing and redetermination process. You should watch out for possible Medicare overpayment. Some scenarios, the carrier processes the charges more than once. The physician receives duplicate payments from both Medicare and a secondary payer. The physician is paid directly on an unassigned claim, and also the payment is made on erroneous information. Our summary for Chapter 6, Medicare is administered by the Centers for Medicare and Medicaid Services, known as the CMS. Medicare is a health insurance program for people age 65 or older, people younger than age 65 with certain disabilities, and people of all ages with ESRD, which is end-stage renal disease. Medicare Part A is for hospital insurance benefits, and Medicare Part B is for medical insurance benefits. Medicare Part C is referred to as Medicare Advantage Plan, or MA Plan. This plan offers a number of healthcare options in addition to those available under Part A and Part B. Medicare Part D Prescription Drug Plan is a standalone drug plan presented by insurance and other private companies that offers drug coverage that meets the standards established by Medicare. On enrollment into the Medicare program, the Medicare beneficiary is issued an identification card. Patients who receive Railroad Retirement benefits will get Medicare from the Railroad Retirement Board. Medigap is a specialized Medicare supplemental insurance policy whose predefined minimum benefits are regulated by the federal government and devised for the Medicare beneficiary. The MSP, Medicare Secondary Payer, is a primary insurance plan of a Medicare beneficiary who must pay for any medical care or services first before a Medicare fiscal intermediary is sent a claim. The U.S. Department of Health and Human Services Quality Improvement Organization program is dedicated to improving the quality of services provided to Medicare beneficiaries. Because Medicare is a federal program, providers that transmit claims to Medicare must comply with billing and coding regulations issued by the CMS. Participating providers and healthcare organizations agree to accept assignment on all Medicare claims and may bill the patient only for the Medicare deductible and coinsurance amounts. National Coverage Determinations, or NCDs, and Local Coverage Determinations, LCDs, are coverage policies that must be adhered to when determining if services to Medicare beneficiaries will be considered medically necessary and payable. The ABN, Advanced Beneficiary Notice of Non-Coverage, is an agreement given to the patient to read and sign before rendering a service if the participating provider thinks that it may be denied for payment because of medical necessity or limitation of liability for Medicare. ABNs apply if the patient is in an original Medicare program and do not apply for patients in private fee-for-service PFFS or Medicare Advantage plans. The CCI Correct Coding Initiative is federal legislation that attempts to identify services that are described by a single code or are inherent to another procedure. An MFS, Medicare Fee Schedule, is a method of reimbursement for services provided by physicians, ambulance services, clinical laboratory services, and durable medical equipment agencies. Hospice, hospital outpatient, inpatient psychiatric facilities, inpatient rehab facilities, long-term care hospitals, and skilled nursing facilities. The Medicare Access and CHIP Reauthorization Act of 2015, known as MACRA, is legislation enacted to establish a new payment methodology to pay providers by rewarding high quality and high value care. Medicare requires mandatory claim submission, which applies to all physician and suppliers who provide covered services to Medicare beneficiaries. The time limit for sending in Medicare claims is within 12 months from the date of service. Instructions for Medicare claim submission can be found in the Medicare Claims Processing Manual, Internet Only Manual Publication 100.04. Medicare sends a payment check in a nationally standardized document to participating providers called a Medicare Remittance Advice, or RA, and a similar document to the patient called an MSN, Medicare Summary Notice.